Well, thank you. It's a joy being at this meeting. It's been delightfully robust and exciting. And what my goal is today is to tell you something about outcomes research using a learning health system. And I want to talk about the promise and the pitfalls. Or I have to push to make it go down.
I think the down arrow should take you.
Okay. More than a decade ago, similar to Joe Cantor, we had a vision that a robust electronic amalgamation of patient health records had the potential to transform future health care. Therefore, we embarked on an investigative strategy to determine whether this strategy was feasible. The short answer is, indeed it is. Now, randomized controlled trials are sort of the hallmark of doing outcomes research, and they are the most reliable methods for outcome research, that is to determine whether a treatment or therapy really works or doesn't, because randomization produces treated and untreated groups that are similar. However, RCTs suffer from many constraints, including cost, long durations to obtain results, and they're restricted severely by the fact that their results only apply to the specific population studied in the randomized controlled trial. They're obviously extrapolated all the time, but nobody knows if the extrapolations really work or not. So, for example, an RCT, typical RCT, cannot extrapolate reliably to determine whether women and men respond in the same fashion, because you break the randomization code if you try to do that, whether all age groups respond in the same fashion, and more importantly, how patients in the real world who do not fit the characteristics of the RCT population will respond. Now, non-randomized, what are typically called observational studies, using amalgamated healthcare data can overcome the randomized controlled trial restraints. However, the treated and untreated populations typically exhibit different characteristics. Sophisticated statistical analytic techniques can reliably overcome identified differences in characteristics of the treated and untreated groups. However, if crucial differences in characteristics are not identifiable, so-called unidentifiable confounding or bias, incorrect results will result. Let me make sure, yeah. Recently, many of you may have seen the front page headline on the Wall Street Journal, which reports that on the increase in observational studies, despite the fact that these studies, according to some researchers, produce findings that are not as reliable as controlled studies. That's ancient history. It's only been known for multiple decades, but they thought it was important to put it on their front page at that point in time. And what I want to tell you about today is that in contrast to that report, our recent studies, which were published in the British Medical Journal, describe a new method that surmounts this problem. What we did is we did a rigorous examination of the potential of an electronic medical record database to yield reliable answers. And we did something very simple. What we did is we replicated previously performed randomized controlled trials using the data from the electronic medical record database to do that, except obviously for randomization. And then we assessed the validity of the database outcome results by comparing them with the randomized controlled trial results. which were presumed to reflect correct answers. And we used well-respected randomized controlled trials that are widely appreciated as having given correct answers. Now, we used the UK GPRD, which is the primary care record database from the United Kingdom, for several reasons. One, it was the only good one that existed at that point in time. Two, it fell into our lap. And three, it had characteristics that we said, if this one doesn't work, none of them are ever going to work because of some of its characteristics. And I'll briefly have listed those here. I think all of them are quite essential. We thought it was very large. It was about, give or take, about 10 million patient records. It turns out that's very small compared to what we really will need for the future, but it was good enough to do some of the work that we did. It's important that it's a representative sample of the entire UK population. In the UK, all healthcare is centralized in the general practitioner's record. So all key patient health events are captured. Furthermore, it's a complete longitudinal record of each patient's care. And it also includes all the medications prescribed for those patients because of the way that healthcare works in the United Kingdom, that the GP does most of the prescribing, and it's all done electronically through the health systems. I forget the term for it, but they're central pharmacy, in effect. Now, what we did is as we said, we compared the results from the database, which I've called GPRD, to the randomized controlled trial results. We predominantly, but not only, we predominantly studied cardiovascular outcomes, myocardial infarction, stroke, or coronary revascularization, that is the combination of angioplasty and coronary bypass surgery, from 5 different randomized controlled trials. The reason we focused on cardiovascular results is I'm a nephrologist, not a cardiologist, but those were the results that were most easy to define with some assurity that you'd be correct within the database. And also, when you try to replicate randomized controlled trials, it's cancer or heart disease takes account for most of them, so you could find randomized controlled trials to study. And if you look at this slide, you notice that on the left-hand panel, it states GPRD was equal to RCT. That meant that the database results and the randomized controlled trial results were reasonably similar, not statistically significant. However, if you look at the right-hand side, you'll see that in 8 instances, they were statistically significantly different. So, yeah, sometimes standard observational studies using good statistical methods give you the right answer, but a lot of times they don't. And remember, we did every one of these studies in exactly the same fashion. Now, the presumption is that when you got the wrong results, it presumably was due to unidentified confounding. And as part of because we knew that when we had wrong results, we were able to develop a new statistical method that we called prior event rate ratio, that's immaterial in the name, to address unidentified confounding. And the bottom line about this method to address unidentified confounding, one, you can use it to determine if the results are reliable, and 2, it can actually give you reliable answers. And I'm going to show you a little bit of that, but not go into too much detail. So this is the comparison of the results using the GPRD PERR method or the GPRD using standard statistical methods. And we used several standard statistical methods. So what you'll notice on the left is when the randomized controlled trial and the GPRD database results were approximately the same, the GPRD PERR results and the GPRD data were approximately the same in terms of the answers. However, on the right is the most important message, and that is when the GPRD results and the randomized controlled trial results were dissimilar, the GPRD and PERR results were, in 7 of 8 instances, significantly different than the GPRD database. So that we basically got an answer that was, and I'll show you in the next slide, very close to the randomized controlled trial, whereas if you use standard statistical methods, you got the wrong answer. And the reliability of the GPRD PERR analyzed results was the same as the randomized controlled trial in 11 of the 14 studies we did. 3 of 14, it was still different, but it was much closer to the right answer than the GPRD results were using standard statistical methods. And we have reason to believe, in terms of a lot of additional work, that you can get fairly reliable answers using this method. This kind of summarizes what I've just said in a simple slide. So on the left-hand side, you'll see that if there is no unidentified confounding, the randomized controlled trial, the database results with GPRD using standard statistical methods, and the database result analyzed using the PER method all give comparable results. When the unidentified confounding is present, the randomized controlled trial gives different results than the GPRD data results, and the GPRD PERR method gives different results than the GPRD standard analysis, but it gives results that are the same or very close to the randomized controlled trial. Hence, you could test validity even if you weren't testing it against the randomized controlled trial by just determining if the observational data results using standard statistical methods and using the GPRD were the same. If they're not, you could be pretty concerned and almost certain that the results are incorrect. On the other hand, if the GPRD results and the GPRD standard statistical analysis results are the same, you could be pretty confident your results are valid. Now, what do you walk away with as the bottom line message for this? The bottom line message is that these studies demonstrate proof of principle that a properly constructed large learning health center can produce reliable answers to outcomes research. There are a lot more work needs to be done. There need to be other methods in addition to ours that overcome unidentified confounding. But this indicates that you can potentially transform healthcare using observational data from a large database. Thank you.